Hey, thanks to everyone for being here tonight with the Colorado Foundation for Universal Healthcare, who will speak to us on universal healthcare and how we'll get there. This is a presentation of the League of Women Voters of Colorado's Healthcare Committee, and I would like to now turn it over to a member of that committee, also a member of the League of Women Voters of Larimer County, and the organizer of tonight's event, Elaine Branyard. Elaine.
Hi there. Welcome, everybody. It's really exciting to get to talk to the League of Women Voters, and is especially exciting after the national vote that is really getting healthcare up top in their issues, hopefully. So it's really great. And I am part of the, like Beth said, part of the League of Larimer County. And I see a few of our members, our healthcare committee members. And also am on the foundation, Colorado Foundation for Universal Healthcare Board. And it's an exciting time in the foundation's work. I don't know if you remember in 2016 that we worked on a single payer system and had a vote of the public, and we're trying to learn from what we did then, and so hopefully this time we'll do a little. And Bill Semple, who is the chair of the Colorado Foundation, and Jim Potter, who is our legislative person, are going to talk to you a little bit about an effort that we're putting forward, a two-step effort to create a universal single payer plan for Colorado. Jim is the legislative action coordinator, so he keeps track of healthcare legislation, much like the League of Women Voters does. And Jim had he earned his law degree from Columbia University, and he's a retired civil rights lawyer with a particular passion for supporting people with HIV/AIDS. And he served as the president of the Chicago Recovery Alliance Board, and then also as an international HIV/AIDS advisor for Concern America in Mozambique. And he's served on a lot of volunteer organization, and his effort in particular is to get corporations out of our healthcare. And he's very committed to that. And he wants universal healthcare for every American, no matter what their station in life. And a quote from him: "Is this really the system that Americans have chosen? Or is it the product of the corporate corruption of our democracy? Money, lobbyists, campaign contributions, and promises of lucrative future employment for legislators have shaped our healthcare policy rather than what is just, moral, and humane. And he's working for a system such as Medicare for All, which covers everybody. And so he's our go-to person for legislative answers. And then Bill Semple is chairman of the board, and his career path was as a clinical licensed social worker, having worked in a community mental health center, and then the last 10 years of his career, he worked in private practice. And so he's firsthand experienced several different systems of healthcare. And he, of course, wants healthcare for everybody. And a quote from Bill was, when his wife was living the last 8 years of her life with breast cancer, by luck, my employer coverage had no deductibles. We had a lot to deal with, but we were not bankrupted. And that is the situation often today. He supports universal health care and won't fully rest until we have improved Medicare for all. So I'm going to let Bill and Jim explain about our latest effort. You can we'll have questions and answers after they present. You can put them in the chat and we will ask them those questions. Very good.
Okay, thank you, Elaine. And we really appreciate this opportunity to share with you. It's exciting that we have a referred ballot measure that is heading to the Colorado legislature in 2023. The plan being for that to get on the ballot in 2023, for the people to choose, to have start a two-step process for people to get universal health care here in Colorado. The context for it is we seem to have an economy that's very good at creating millionaires and billionaires, but not very good at meeting all of our needs. And we hear a lot lately about the social determinants of health. And unfortunately, one of the major negative social determinants of health is actually how we pay for healthcare. The impoverishing that so many people experience just getting needed healthcare has a ripple effect and into a downward spiral into the quality of health. So we're excited. The Colorado Foundation for Universal Healthcare was, as Elaine mentioned, we were involved in Amendment 69 back in 2016. And that was a citizens initiative and an amendment to get universal healthcare. And so we tried to look at, so what are the lessons that we need to learn from that, so that, because we sure want to get more than 21% of the vote next time. And this is, there's been 6 years in between. Bernie Sanders has done what he's done. And I think we are all seeing how we still really struggle with healthcare and getting good healthcare. So one of the things we've learned is that simple is better. We tried to rewrite Amendment 69 to be sort of clearer and less legalese and more plain English. And it still ended up having a whole lot of detail, and there's no way to call it simple. So that's why we moved to an approach that has, in the first step, affirming 10 essentials to what a good healthcare system would be. Other lesson learned is that a lot of people, in part because of Tabor, are really averse to an amendment to the state constitution for most anything. And so instead of doing the amendment route like we did 6 years ago, we're working on a statutory level. And related to this, and that in Amendment 69, we did it was a citizens initiative. So we collected 56,000 signatures, and that's a tremendous investment of time and energy. And those conversations that we had, I think, were very worthwhile, but still it limited our ability to have the time and energy and resources to make connections with other organizations, which has a tremendous multiplier effect. And I think there's some groups like the Colorado Fiscal Institute, NARAL, Planned Parenthood, who came out against us, where I think if we had spent more time reaching out to organizations, we could have found a way to get for them to be on board. So that's you doing a referred ballot measure through the legislature. It allows us to have the time and energy to reach out to other organizations, including the League of Women Voters. So the other thing that we thought we're working on is avoiding Tabor. because paying for healthcare, the funds that would go into paying for healthcare would be a fee based on income, based on ability to pay. It and would not go. It would go into a separate fund. It would create an enterprise, and so that's a way to avoid having the limits that Tabor can have that can confound everything. So these are some different lessons learned that we hope that will make things work a lot easier. Let's see the other thing. So we're thinking of 2 steps, and the essentials are like 10. We've come up with 10 bullet points that are, and each of them are important. But seeing them as 10 bullet points, they're important to see as a whole. A lot of efforts at healthcare reform have been incremental, thinking that, well, if you fix this or this or this, things will be better. But if you leave the corrupting profit motive within the system, then any incremental improvements, you end up playing whack-a-mole. And so it's important, and it's important for, I think, people to see what the essentials are for a good, not-for-profit single system. And for people, so some of what we're doing with the first step, it's really an educational process. It's to tell people to show people what a good single system would look like, so people can see both the individual pieces and how that all comes together as a whole, and so that the public at large, which already supports Medicare for all, will be inoculated against the fear, uncertainty, and doubt that the special interests that exist are sure to come out against. So we're thinking that the essentials would be referred to the ballot in November 2023. And if the voters approve that, the second step would be in the next session for implementing the legislature to come up with implementing legislation that would embody the 10 essentials. So that's a very quick overview. And I think I saw an email that you've been able to see what those lists are. Don't want to go through them individually necessarily, but really want to open up the questions and want to see, Jim, if you have anything else that you want to add that's overarching important, and if there's anything that you'd like to add, and then we'd like to open it up to your comments, your concerns, your questions.
I don't know. Is Jim speaking?
I'm not hearing him, and I can't see if he is muted or not. And I know he has rural Wi-Fi, so he may be having a connection issue.
I think
is,
that's what it is. I'm not seeing that Jim is here right now.
ah. um, Darn.
Who has questions for Bill?
Yeah, why don't we start there, and then when Jim gets on, yeah, we can go from there.
Bill, this is Jan Phillips.
Hi, Jan.
I love what you're doing, and thank you so much for putting all of this together. And as I have been speaking with people in my rural community about this, there's so much disgust and frustration that even though I know you're trying to keep it simple, which is smart, I know they're going to ask me specifics, like a premium based on your income, but what is that? And how do I compare it to what I'm paying now? And, you know, people think in terms of taxes, and that scares the heck out of them, no matter what the improvement would be. So any thoughts on where it would be for premium?
Well, with Amendment 69, our estimate was that about 80% of people in Colorado would be paying less for healthcare. And the 20% who would be paying more only during those years when they're earning, you know, much more than average, and they're the people who can most likely afford that. And you know, we all have probably those years when we're first starting out in life, where we're making less money, healthcare would be guaranteed. With good fortune and good work, and you start making a lot more money, the 20% would be paying more, but 80% of people would be paying less. And I think that would be probably pretty close to what we come up with. You know, healthcare is a little more expensive now, so but I think the percentages would probably be pretty similar. And so we don't have a fiscal note on it yet. And I think for the first step, I'm not even sure. We've started the conversation with, we've had an initial conversation with Legislative Legal Services. And so they're kind of wrapping their head around this process. Maybe sort of another idea or another thought is a comparison that when we legalized marijuana here in Colorado, we did a similar two-step process. You know, rather than figure out all the details first of, you know, how do you legalize marijuana in one state when it's illegal nationally, you know, all the details of it. So the first step was, you know, shall it be legal? And the voters voted yes. And then the second step was, okay, how are we going to do that? And so I think that's it's in some ways the down. When people see something simple, they want the details. When people see details, they want to know what's the overall picture. So there's no way to do both necessarily. We do have model implementing legislation that we gave to Legislative Legal Services, and perhaps at some point it might be helpful for some people who really want to see okay, how would this be implemented. We could show them, but most people, I think, don't want to go into that wonky level of detail. And indeed, the way it's set up as a two-step process, we couldn't promise how it would be implemented. But the important thing is, I think, is to shift it from where the janitor and the CEO pay the same premium, but the CEO makes what, 300, 400, 500 times more. We want it proportional to a person's economic well-being.
Jim did make it on here.
Oh, good.
Yeah, sorry, folks. My internet here is terrible, and it has been really fritzy of late. Kind of goes off and on, so I apologize if I kind of disappear from time to time.
Jim, did you get to hear what I presented, and does that leave you with some other things that you'd like to jump in on?
Well, I'm sure I missed a good part of it. But I think I got the general drift of what you were saying, Bill. And that is sort of our plan. It's an advisory referred measure to gauge public opinion so that the legislature will not be so hesitant to pass a more detailed plan. They'll see that the public wants a single payer plan for Colorado that will be cheaper than what they're paying now, that will actually create jobs according to the 1176 report, and that will have more comprehensive coverage than private health insurance without the copays and deductibles that prevent people from accessing healthcare. So that's the big picture that we want to present to the public just to get their feedback on it. And that will kind of give the legislature a mandate to go forward with a more detailed plan.
Did you want to review the essentials?
Well, if you'd like me to do that, I can go ahead and do that. So basically, there are 10 essentials. The first is that it's going to provide comprehensive benefits for all medically necessary care, including dental, hearing, vision, and mental health. The second point is that it will provide home care and long-term care, at least at the level of coverage that is currently available under Medicaid in Colorado. That's to assure the disability community that this is a plan where they won't lose anything, and that will be a floor, not a ceiling. So we want to provide even more comprehensive benefits as we move along, but we want to put in that assurance. The third point is that medical decisions will be made by physicians and their patients, not by health insurance intermediaries. The fourth is that patients will have free choice among qualified providers. The fifth is that we will address healthcare disparities by covering everyone, including the undocumented. The sixth is that the system and the cost of care will be funded by premiums based on ability to pay. That's a really important provision because, as Bill said, right now, premiums are not based on what people can afford. They're based on what the insurance companies want to make in terms of their profits. And so they charge what the market will bear rather than what people can pay. Also, the system and the cost of care would be, it'd be prepaid by premiums. So there would be no deductibles or copays that create those barriers. Number 8 is the agency would be able to negotiate drug and hospital prices. 9, it would be a publicly administered nonprofit enterprise and would be the sole agency that would make healthcare payments. And last, to avoid profiteering, there wouldn't be any middlemen in the process. That is, those kinds of entities that have an interest in making money by limiting benefits or imposing other barriers to care. So that's the 10 essentials in a nutshell. Now, this is still a work in progress. I mean, these are the 10 essentials that we've come up with within our foundation group in consultation with other organizations that have partnered with us. But there will be further kind of legislative hearings, there will be stakeholder meetings and things like that. So some of these provisions are likely to change over the course of time. And as this moves through the legislative process, we welcome that kind of input because I'm sure we didn't think of everything that is absolutely essential, but we want to get that general idea across.
I see, Jan, you had the question about would labs and other testing be covered, and the intention is yes. The intention is for this to be the full range of modern healthcare is what will be covered, and without any cost at the point of service. So no deductibles, no co-pays, so that when people go and meet with their provider, the focus is on what care is needed and what care is not needed, not how the heck are you going to pay for it.
And I see Betty Seelan wrote in the chat, who would actually develop the plan if given to the General Assembly to do? How would your organization be involved?
We'd like to be involved a lot because we're sure the vultures will be circling overhead, wanting to ignore especially some of the essentials that need to be in there. So I presume that the legislature would establish some sort of commission to come up to look at these essentials and come up with the details. We do have model legislation that we can hand to them that would help them to fill in the blanks. But that would be up to them.
Yeah, this would be basically the bill sponsors are going to come up with the initial draft of it, and then it will go through the committee process like all legislation. And, there will be changes along the way, and we will be carefully monitoring that and lobbying ourselves around all of those issues.
And I see Kathy Wilson has her hand up.
I do. I have just two really, really basic, I'm almost embarrassed to ask them questions. We use Medicare right now because of our age. Is this, would I continue that and not do the universal health care? And the one point, and kind of related to this, one of your points was that people could choose the healthcare providers, or what was the choice one on your 10 points?
That is that there be no narrow networks. Basically, any
Got it. Okay.
either licensed or certified provider in Colorado would be eligible. So we would be free to choose whomever we want to see, rather than
Okay.
the insurance bureaucrats saying this is the narrow network that you want to see to be a network.
Okay. Back
And,
to the
and
med-
but I can answer the Medicare one since I'm on Medicare too, and it's an issue. There's a possibility to get waivers for Medicare, Medicaid, and if that could go to Indian Health Services and VA or TRICARE, there are possibilities for waivers for that, so that the federal dollars, as much as possible, could be included in the single Colorado system. That would be the ideal. You can't apply for the waivers until you have a state, a formal state plan in place. So we can't say for sure that Medicare would be included, and the benefits I think would be much better, because with traditional Medicare you need to have a supplemental plan, or you're on the hook for the 20% co-insurance, or you get into a Medicare Advantage plan, and that's fine when you're healthy, but when you're sick and need healthcare, then you're up against the prior authorizations and claims denials and narrow networks that Medicare Advantage has. So it would have significant advantages for people on Medicare, whether in traditional Medicare or Medicare Advantage.
Great, thank you.
Yeah, one detail that is in our draft plan is that Colorado Cares could become a supplemental plan for all Medicare beneficiaries, or might even become itself a Medicare Advantage plan. So it would provide greater benefits than current Medicare, but without the narrow networks and all those other problems with traditional Medicare.
All right, thank you.
So, and how we're thinking, this would be a question for step 2. after it passes the ballot in November 2023. So those are those important details, and that's step 2.
And Barbara Kidd.
Hi, question I have, and maybe this is for step 2, having worked on Amendment 69. What about employer plans? Because in talking with people back then, those that had employer plans, some of them loved them. And so I'm wondering if this would eliminate that, would this give people the choice? So that's one question. And then the other one is, which you partially answered with respect to Medicare. I'm sure you're aware of the DCEs that are coming in and apparently becoming the middleman between Medicare and providers without patients' knowledge. And that's a concern when you say, oh, everybody else could end up on Colorado Cares, and then the Medicare people might come later. So again, maybe that's step 2. So those are 2 questions.
Those are important questions.
Yeah,
And
to
that's,
address. Sorry.
go ahead, Jim.
Sorry. Yeah, to address the employee benefit plans, I think what we have in mind with that is that if Colorado Cares is passed, it would be the sole payer. Everyone in Colorado would be covered. So employee benefit plans would no longer be necessary. And employees and employers would likely drop those plans because they're not going to want to pay double taxation, one for the universal plan that we're proposing and the other to their private health insurance plans. So we think that, over time, the incentives to dispose of employee plans take us up on having a universal single payer plan in Colorado with even better benefits is going to push employers and employees into the single payer plan.
And it would be better coverage than most any private insurance plan.
But did we answer all your questions, Barb? I think you had another one too.
Well, only with regard to, and I understand about your having to get the waiver before, people on Medicare or Medicaid could get on. And I'm very concerned about these DCEs coming in, but again, you can't control that. It sounds like you'll just have to wait and see what happens. Unfortunately, it sounds like those that would not be on Medicare would end up with better coverage than those on Medicare. Anyway.
Betty Sealand.
You're muted, Betty. Yeah. Betty, looks
still
like you're
mute.
muted.
Yep.
There you are.
Okay, I put the question in the chat also. We're on Kaiser. How do you actually get the people that are in these programs into the universal healthcare system, or the hospitals, or the doctors? I guess I just don't quite understand how it can all work, particularly when we're the only state doing it, when it's not nationally.
Okay, well, I'll take that one since I'm both on Medicare and Kaiser Senior Advantage. And in many ways, I like it. There are a lot of good things that Kaiser does. A concern I have is that there's a profound conflict of interest that Kaiser has being both a provider and an insurance company.
Mm-hmm.
And so my expectation would be that I think Kaiser could have a leg up on being an integrated healthcare delivery system because that's what they are already. And I think their service actually would be better. You know, their healthcare would be better for us if they were no longer an insurance company. So I think Kaiser could continue very much as being solely a provider. And so that would be, they could continue to offer insurance, but like Jim was saying, that would be duplicate. I think the way it would, in step two, the way it would be set up is that Colorado Cares, the enterprise, would be secondary to any private insurance. So there'd be no so people would have to pay premiums twice, one to the private insurance, and if Kaiser wanted to continue as a private insurer, they would be the primary coverage, and then Colorado Care, the enterprise, would be secondary. And so, and there'd be no good reason. They would be forced to no longer be an insurance company. So it's a disruptive. It's a big change.
Yeah. So do
And
people
it's disruptive. Pardon?
So do people choose to go into the Colorado Care? Is that a personal choice whether they want to stay where they are or join this new program?
It would be a choice, but you would have to pay into Colorado Care. So in effect, it would not be a choice. You would, since you would be paying into Colorado Care based on income, and if you're a Colorado resident, you would be covered. So you would be required to pay in. So there would be a profound disincentive to have any additional healthcare insurance.
And
it would be much better healthcare coverage than what you have. So it would be much better coverage.
Yeah.
I see that Tiles is asking about other states. And there are other states working. Washington State actively has a citizens initiative campaign going on. Because Colorado is one, and so is Washington, about half of the states in the country that allow citizens to put initiatives on the ballot. And so they are doing that. Oregon is working hard, California. There are other states that are working. And of course, there are some states where they don't even have Medicaid yet. So, and we know that in our healthcare organization, HCR for UHS, which is healthcare reform and meets once a month. And that's a League of Women Voters organization. But some of the people on that call, I mean, they don't even have Medicaid. So we're quite a bit ahead.
I think some of the thinking is having a national plan would actually be more ideal. It makes more sense, but getting there through the federal government seems like even a longer reach. So the hope is that Colorado can be a leader. Several states could be a leader in showing that we can get cheaper, better, and fairer healthcare. And that there's a way to do that. And once there's a model for that, and this is actually what happened in Canada. The province of Saskatchewan in the early 60s created a single payer system. And it was like a domino effect across the country. The other 10 provinces, the 9 provinces, they all, so that there's national health care, but it's based on province by province. And so Saskatchewan led the way, and so we're hoping that that even that Colorado would in some ways be an interim step towards getting our country as a whole to have much better healthcare.
A single spark can make a prairie fire.
Sometimes a good thing.
Well, I have another question. Have you talked to state legislators? Are there any state legislators who are working with you at this point or on board with this? I guess that's would be a question for Jim, maybe.
Mhm.
Well, yes, we have both a Senate and a House representative who are sponsoring this bill. And we are having our first kind of gathering with them, a stakeholder meeting on August 15th to get more into the details and get along the way. So Senator Sonia Jaquez Lewis is our Senate sponsor, and Andrew Bazenecker is our House sponsor so far. But there are other sponsors that are waiting in the wings to join in with them too. And we're getting really positive signals.
I know Chris Kennedy has done a lot of healthcare things from Jefferson County.
Aha.
He's been invited to the meeting next Monday.
Okay,
And you,
representative, so.
you might want to reach out to him if you're an advocate.
Yeah.
I'm still really puzzled about how this is actually going to work. It's just such a large undertaking and so important and so critical, but it's so complicated, and there are so many agencies out there that are opposed to this sort of thing. There's so much money involved that good luck.
Yeah. You know, one of the things we're aware of is that there's a very natural human aversion to change. That in that we humans tend to overvalue what we have, even if it's not working very well, and undervalue what might be, even though it might serve us much better.
Mhm.
So that's a reality that we have, and that's part of the reason we've shifted to try this two-step process of trying to make it as simple as possible while having enough detail to really say, you can look at these 10 essentials and say, boy, that looks like a system that could work and really work well and work much better than what we have now. And that can give both the courage and the gumption to make this kind of big change. And it also can inoculate people to the fear and uncertainty and doubt that the vested interests are going to certainly come up with.
I think also the political landscape has changed, especially with COVID. You know, earlier we were talking about employee benefit plans and how people love their employee benefit plans. Well, when they became unemployed, they lost all of that. And that's one big lesson of COVID. You cannot rely on your employee benefit plan to cover you unless you continue to be employed. And once you're out, you're really out. And I think people have learned that lesson, and I think they're much more accepting of political change.
Wouldn't employers be all for this? They wouldn't have to provide the insurance, pay for it. Then they could give their employees raises because the employees are going to have to pay for it.
It could be said, that the employer would make some contribution, that it might be a combination employer-employee kind of setup. That could be, but it would be much less than the average of 10, 12, 15% of payroll that employers who do provide health insurance do now. Plus, they wouldn't have the headache of it. It would be just like
Exactly.
figuring out FICA. It's just a certain percentage, and you do the math, it'd be, and they're not responsible for it. So they don't have the headache, and they don't have to listen to people's complaints. So I think businesses tend to be more sort of value the private marketplace. And so it ideologically can be a stretch for them. But in terms of dollars and cents, yeah, it's a no-brainer.
Any other questions?
How about how can League help?
Oh,
One
there are
thing
lots of things.
is,
go ahead, Bill.
well, I'll throw in one anyways. I don't know if the league is open to signing a petition, but one of the ways we're looking to show broad-based support is having organizations, individuals and organizations sign a petition encouraging the legislature to refer this measure to the ballot. So that's one thing that the League of Women Voters can do.
And you can post about it on Facebook. You can contact your Colorado state representatives. You can tell your friends about it. You can also tell other organizations that you belong to sign on to it. All of those things would be helpful.
Hey, any other questions?
I'm not sure that we've answered all the questions that were in the chat, so we need to
Oh.
check on, please.
Let's see. Oh, I see one, Jan. But I think maybe that was asked and answered in a question about the consistency across the state.
And again, this is
Yeah.
a step two, question. What they've done in Canada is that they have what they call individual global budgets for each separate hospital. And so that's a way of acknowledging that some hospitals provide specialized services that may need to be funded. And the global budget means that they don't have to be tracking every tiny little thing and that they do, and they can be more focused on the overall treatment plan that they have for people. And it may be that there would be some incentives for rural hospitals. So this could be a way to increase the viability of rural hospitals, which are so vulnerable these days, and including in Colorado.
There are lots of people, that are rural people, and they don't have, what I'm hearing is that there's the rural hospitals, it costs more to go to the hospital there, and, I think, is it the same, going to be the same? Let's say you broke your leg or whatever, and will it be be the same to go to have a little surgery of some sort in Denver versus, like another Grand Junction or some other place,
As a patient, it would be the same. As a patient, it would be the same. Because, well, there would be no cost at the time of service for the patient. For the hospital, for the institution, there may be different ways of working out the budget for a rural hospital, which can have more difficulties and expenses that a larger urban hospital that has maybe some economies of scale doesn't have. So, but the model, one of the essentials is that there's no cost at the time of service. And so as a patient, you would, whether you go to a rural hospital or an urban hospital, there might be differences in what the services they'd have available, but the cost, there would be no cost.
And rural hospitals and many other hospitals might well find that global budgeting is to their advantage because they would be paid just like a police or fire department. You look at what their annual costs are, and these can be adjusted over time. And then a budget can be made for that particular hospital and its particular circumstances as they change.
And I see Andrea, you have your hand up. Can you tell us a little bit about what your role is in the legislative maneuvering?
Sure, absolutely. I'm Andrea Wilkins. I'm the legislative liaison with the State League. And one of my key responsibilities is to provide technical and logistical support to the League's Legislative Action Committee. And kind of getting back to the question of what the League can do to help, it's probably a bit early in the process to say for sure, but I'm wondering if you have any sense of when you may have a draft of the referred measure, and if that's something that you would be interested in sharing with us and potentially allowing us to provide input on.
Do
Sure.
you want to take that,
We'd be
Jim?
happy to share. Yeah, it's a work in progress, as you know, because we are meeting with legislators and stakeholders, and we're also meeting with legislative legal services. And so a lot of these details that we're talking about today are going to come out in the course of those meetings. So our expectation is that this is an ongoing process, and we'll certainly let you know at each stage where we are.
That'd be fantastic. I am sure that our lobbyists that focus on healthcare, as well as members of our healthcare task force, would be really interested in seeing a draft if you all are willing to share that. So I know it's a work in progress and not something that'll happen immediately, but when it's available, we'd love to take a look.
We do have an initial tentative number. It's LLS 0015. But we don't have a copy of it yet. And we've had one meeting with Yolanda Love from Legislative Legal Services, and to help her to see where we're coming from. And she was kind of a little taken aback by this two-step approach. And so I think she was wanting to talk to her colleagues. And but we definitely will want to keep you informed. And I presume Elaine will have your contact info.
I'm not entirely sure. Both my and Beth's contact information is on our website, but I'm also happy to drop it in the chat here so people will have easy access.
Okay.
And I see that Beth has another question.
Oh. Yes. Is there any way you can control costs with this plan? You know, if this pays for everything, how do you keep them from overcharging for drugs and hospitals and everything, but procedures and that sort of thing?
Well, it actually will do a much better job of controlling costs. Right now, basically, I think it's accurate to describe the insurance, drug, and hospital corporations as a legal price fixing cartel.
Mm-hmm, mm-hmm,
They charge whatever they want.
mm-hmm.
why charge $200 for a lit insulin when you can charge 400? And you know, you're going to die if you don't have it. So of course they're going to do that. And so what this will do is give the 5 million plus people of Colorado the bargaining position to talk to drug companies, to talk to hospitals and say, you know, well, we want you to have a fair price, but you're not going to gouge us. And they're going to, and the enterprise will have the heft and the bargaining power to get fair prices.
Okay,
The VA does this now. They pay half as much on average for medications than Medicare, because the VA can negotiate.
mhm. So the enterprise organization would be the one that would do the bargaining and take care of that. Okay,
Which is what we as individuals, we're not in any bargaining, when you in the ER, you're not in any bargaining position.
no,
Yeah, we're not in a you know, I'm a senior and I've been put in ACO REACH, and there's no bargaining at all. I was put in this thing, it's privatized, and I had no education about what the changes are. Didn't even ask me permission. They just did it. So what is happening? We're getting privatized Medicare or health care, and they take the money from the people that can pay for it, and that's how it is. So we will save a lot of money going through a single payer situation.
Yeah, as
Well said.
well as the, yeah, as well as the administrative simplicity, both on the payer side and the provider side, that can lower costs significantly. We can set it up to incentivize primary and preventive care much more than we do now. And so in the long, there'll be some initial increase in costs with that. But in the long run, there'll be much less need for specialty care. You know, people getting insulin and getting that you know have type 1 diabetes are getting insulin because they get it and they don't have to cut their dosage in half. They're much less likely to end up in the ER in a diabetic coma. And so there are a lot of long-term savings that we can have by better primary and preventive care.
Any other questions? We're just over an hour. We will send a link to the recording of tonight's presentation, as well as a copy of the document 10 Essentials for Universal Health Care.
Right.
We will also send a link so that anyone who's interested might join the League of Women Voters of Colorado Healthcare Committee. Anything else? Anything else you'd like to say, Elaine? Of course, a big thank you to our speakers.
Yes.
Yes, yes.
Yes, really
Thank
appreciate
you
your,
all.
yes, thanks, Bill. Thanks, Jim.
Mm.
Really appreciate the information. And again, I'd really like to thank Elaine for organizing this evening for us. Really appreciate it. Really appreciate it, Elaine.
Very good. We,
And thanks for all the work that the League
Yeah.
does. Our democracy needs this.
Yes, we do.
Okay, Elaine, did you want to say
well,
anything else?
I just encourage everyone, I believe that I sent out on this afternoon on the forum, Healthcare Committee Forum, is Bill's excellent article, which was in the Colorado Sun. I don't know if you've been able to read it, but it's a really good kind of overview that is easily shareable with other people, and encouraging other folks to read it too. So, and I think, and we have a grassroots meeting every fourth Tuesday of the month. And that's just a real relaxed meeting, and we encourage people to attend. And you can find all of that in the foundation website, all the details. And Jim authors a great Facebook, if you're into Facebook, but he finds articles every day just about that really keep you informed about what's happening. So
It's called Colorado Healthcare Action.
Okay.
very good.
Well, thanks again, everyone, for attending. You can expect to hear from us tomorrow with some follow-up materials. And please stay interested, stay active, and stay involved with the league. Thanks so much. Have a lovely evening.
Thank you.
Thanks, everyone.
Thank you. Bye.